Looking very expectant, Kieran. Hello. Hello. Thank you so much for coming out on a Saturday morning. So welcome to Coin Street. I'm not going to say very much now. Rachel's going to be a bit of an introducer. But my name's Olivia Butterworth. I can't thank you enough for showing enough interest to really want to come out on a Saturday morning. It makes it worthwhile. My alarm went at 4:45 this morning. And I went, if I arrive and there's only about 5 people there, I'm going to be really grumpy. But actually, there's loads of you, so that makes it worthwhile. Thank you.
Hello, everybody. I'm Rachel Quinn from Regional Voices. Thank you all, as Olivia's just said, for coming out today. A very quick bit of housekeeping before I hand over to Kieran to do the introductions. Obviously, we're downstairs at the bottom of a building, so there are no fire alarms planned today. If there is an alarm that goes off, we've got an exit point straight outside these doors and turn to the right and just follow the signs. They'll take us out to the car park where there's an assembly point. There are toilets out there and there are toilets out this corridor as well for anyone that needs them. We will have teas and coffees coming during the day, so there's another break at about 11:30 before we go into table sessions and then lunch at 1:15. So you get fed as well. It's marvellous. The one thing that I really do need to flag up is that we're delighted to welcome Public Eye here today. We are live webcasting this, and I know that people have been told on the way in, but just to flag that up again, we have a table in the far corner which won't be picked up on any of the cameras. So if for any reason you'd like to not be on part of the webcast, then we suggest that you sit at that table and we'll make sure that you've got all the stuff you need to participate in the discussions. If you do want to speak during any of the group sessions and for that to be recorded, you need one of these so that we can pick that up and it can be keyed into the webcast. And we'd really like to pick up as much as possible so that people that couldn't make it today can still participate, can still see what's going on. So please do that. Apart from that, I think Olivia will make sure that we capture everything. You've all got paper on your tables, anything that you think of, and there'll be clear guidance on how to use the paper and the pen shortly. And like a Twitter person, we're using a hashtag Care.Data. And if you need Wi-Fi for this room itself, then the Wi-Fi network is CSNC1. And the password is capital E, VENT 293. So that's event with a capital E 293. Apart from that, I really hope you enjoy your day. We've got numerous facilitators around and we'll be in and out helping you make sure we capture everything. Thank you.
Okay, good morning. I'll stand. It's probably easier. My name's Care.Data. Day job, I'm the Chief Exec of Macmillan. But I was asked, really because I'm a non-exec of NHS England as well, to chair an advisory group which is outside the project, so we are not the project team. And the idea was that as the project moves forward and recovers from its, what's the right phrase to use, the stumble of earlier in the year, that there is a process by which we have a slightly outside view of people who might be deeply expert, and then ask the members of the advisory group who are here to introduce themselves in a second, but also that we have conversations with people. So as the project itself goes out and says, okay, what are people thinking, what are people worrying about, that we as the advisory group have talked to people like yourselves, and we say, yeah, actually that makes sense because when I was in that room in that basement in Coin Street I heard this. Or we say, well, actually that's different because we were hearing something different. So this is in a way a quality assurance process. It's us as the advisory board checking that what we are thinking as the kind of the geeks in the process actually chimes with what you as people who are interested think. Does that make sense? Okay, a few nods, that's good. Okay, who else is here from the advisory board? Can I just ask you very quickly to say hi and who you are and what's your day job and where you came from? We need to run you a microphone.
Hi, I'm Sam Smith from Med Confidential. We are a advocacy organisation around safe, consensual and transparent data use in and around the NHS.
Brilliant. And over here.
Hi, I'm Cynthia Clark, and I'm working on a campaign called patienceForData.co.uk. and we are a pro-data group that is hoping that data will quickly be put to work to improve care and research in the health care system.
Yeah. And just to give a view, a flavour of who else is on the kind of the expert group, the Wellcome Trust are there is a big research charity. We've got University College London Partners. We've got Big Brother Watch. Who else? One of the mental health charities, Mind. There. So we're trying to have a spread of people who come from a patient point of view or a research point of view or an expert point of view as well. Okay, that's it from me. I'll be around, so if you do have anything particular you want to make sure I hear and hear clearly, do nab me at some point. And now back to Olivia.
Cool, thank you very much. No, it's not. Oh, it is me. Sorry. Okay, so a little bit about how today's going to work. We're going to hear very shortly from David, who's going to give us some factual background. We're going to play a little video clip that some of you will have seen. David's going to talk us through a bit about what the programme's trying to achieve, how it's trying to do it. That's about setting factual context. Our role here today is to facilitate your voice to be heard by the advisory group. So technically speaking, this isn't an NHS England event, it's an advisory group event. So we're here to facilitate you to have that conversation with the advisory group. Can I just ask the table facilitators to stand up and wave so people know who you are? Ruth, own up to being here as well. And Beverly's outside just waiting for the last few people to turn up. So they're here. They will help you, guide you through some of the questions we've been asked already, some of the issues that are being discussed. They don't have the answers. What we really are after is thinking about, so if this is an issue for you, what would be a good resolution? What would be a good way of taking that forward? How would that make you feel comfortable? How would that assure for you that you've been listened to and your concerns have been taken on board? We'd really like, by the end of this morning, to come out with the real crunchy things where you say to Kieran and other colleagues from the advisory group, actually this remains a really, really big issue for us. We haven't heard anything. We don't know what's going to resolve it, but we want you to take it away and really think about it. And the other things where you think, actually, this has been an issue, but I now understand a bit more about it. If you did this, that would help other people and me think about it in a different way. We'd like to get towards thinking about what the potential solutions from your point of view might be. But I can't reinforce enough. If you ask me technical questions about Care.Data, I do not know. Okay, David will do his best to respond, but David's been around for 6 weeks in post. So I ask you to give him a little bit of slack, to be fair. Okay, so the sticky wall. This is really important. This is the most important thing in the whole session, okay? This is a sticky wall. It's sticky. If you put bits of paper on it, they stick to it, and then they come off again. So we want to capture things on the wall. We can move them around. We can put them up. We can take them down. But it's your things that go on the wall. And I'm quite specific about what you do in terms of writing on the cards. Can you try and stick to one issue per card? We've got loads of bits of paper. You can use as many bits of paper as you want, but one thing per card. If it's one thing, it's probably around 3 to 7 words. If it's less than 3 words, it's not going to be very descriptive or clear in terms of what you actually mean. If it's more than 7 words, it's probably 2 things, so use 2 cards. This is the most important bit. I did used to work in a secondary school, if you think I act like a teacher at all. It's true. Can you write big, please, like that? Because then, when it goes on the wall, most people can read it from a reasonable distance, and we can photograph it, so it's really clear and we can capture the conversations. If you write small like that, we can't see it. Okay, so that's my patronising school teacher piece about how to write on bits of paper to go on the wall. It's quite important to me, you might have noticed. So at the end of today, we will capture all of that. We will capture the conversations. We will have some of the webcast footage from today, and all of that will go back to the advisory group, and it will further inform the next session, which we hope will probably be around the beginning of November time. But we'll get back around what that then looks like. That's all I'm going to say for now. Oh, we will finish with lunch at 1 o'clock, 1:15ish, but we won't keep you after that. But please stay and eat something. David, you're going to do a play of the video and then talk to us. Yeah?
Yeah,
Cool.
That's right. So just to bit of background, my name's David Corbett. I'm Programme Head for the Care.Data programme. As Olivia said, I've only been on board for a few weeks, but obviously I'm very, very happy to try and answer any questions that you've got from today. But I think it's really, really key to really reiterate that this is an advisory group run event. It's not a programme event, but really from behalf of the programme, really, really pleased that so many of you have come along today. Just in a moment, I will provide a bit of background on Care.Data and talk about a little bit of the progress that we've made collectively with lots of partners over the last few months. But firstly, I'm just going to show a video that was produced as part of the earlier communications campaign. Appreciate that some of you will have already seen this, but I'm sure there'll be some of you who haven't.
Hospital. The NHS collects information about us. Our information is used to check the safety of different hospitals, to study the quality of care across the country, and to help plan new health services. We've all been benefiting from information like this for decades, but at the moment the NHS is missing information about much of the care provided outside hospital. This is a problem because it means no one really knows how well all the different parts of the system are working together. To help tackle this problem, the NHS is going to start collecting information about the care provided outside hospital, and we're going to collect some information about hospital care that's missing at the moment, such as details of tests and medications. Together, these improvements will provide a better, more complete picture of the care being delivered. Soon we'll know about the quality of care that patients receive as they move between all the different parts of the system. We'll see where the NHS needs to invest more in different parts of the country and in treating different diseases and conditions. We'll find out where the NHS is providing excellent care, but also where there may be local problems that need to be fixed. However, you have a choice about taking part. If you are happy for your information to be used like this by the NHS, by researchers and other approved organisations, then you don't need to do anything. But if you'd prefer not to take part, just contact your GP practice. The NHS believes your confidentiality is extremely important, and we will always comply with all our legal duties to protect your information. This is an opportunity for each of us to help the NHS deliver high-quality care for all. For more detailed information, go to www.nhs.uk/care-data.
Okay, so firstly, just really want to give a little bit of background on what Care.Data is. Appreciate there'll be probably mixed levels of understanding in the room around that, but really think to kind of set the scene, we really wanted to provide a little bit of background first, just so everybody has a broad level of understanding. So effectively what we're looking to do with the Care.Data programme is to make sure that information and data is made available to a wide range of audiences, but in particular clinicians, people who commission healthcare services, to patients, to charities and to researchers. And fundamentally what we're looking to do with that is to ensure that there are improvements to be made to the effectiveness, safety and the quality of care delivery. The NHS England have commissioned the Health and Social Care Information Centre, which is an organisation in the middle of that, to build on existing data sets that are made available or currently available in the health and social care system. And what they've asked us within the Health and Social Care Information System Centre to do is to enhance some of those data sets so that more joined-up data can be made available across all care settings, so not just secondary care, across mental health, ambulance, other care settings, really to improve the quality of care for everybody and to have a much more rounded picture of how care is delivered. So currently, in the health and social care system, we have some of the best information systems in the world. I'm sure a number of you will be aware of that, but certainly across the world we're renowned for having some very, very good information systems. And certainly since the 1980s, we've been collecting data for every single hospital admission across the country. That information is brought into the Health and Social Care Information Centre and then aggregated. And that information has been absolutely invaluable in terms of being able to monitor and track care delivery, in helping to plan healthcare services, and also to help researchers identify information that's helped to improve treatments for patients. What we've got currently is a system that hasn't got all the necessary information altogether. So there's lots of care settings that don't have great detailed information systems, and that information's not, as it stands, currently working together. So what we're not able to do is provide a rounded, complete picture of how care is delivered to individuals. We've just got single parts of the jigsaw. So what we're looking to do with Care.Data is to support more information from more care settings to be made available and linked together to give that much more rounded and complete picture to clinicians, to patients, to charities, to researchers, and to those people who commission and deliver healthcare services, so we can really see the full end-to-end picture of how care is delivered across the system. So just want to touch on some of the intended benefits from Care.Data, and I think it's important to clarify that all these benefits aren't derived by having a Care.Data programme, but Care.Data is an enabler that helps to support these benefits. So firstly, we're looking to help ensure that the highest standards of care and clinical safety are consistently met throughout the NHS, and to provide alerts where standards drops and prompts to action. We're also looking to help understand what happens to people, especially for those people with long-term conditions who are cared for particularly away from hospital, and to ensure that their needs are met with targeted and effective resources. We're also looking to provide the vital information that's needed to assist and support research into new medicines, prevention and better treatment of diseases. So just again want to touch on some benefit examples. So one example is to help NHS services deliver early diagnosis of conditions such as various forms of cancer, improving how patients respond to treatments. So for, an example of that is currently patient might present to their GP with symptoms, bowel symptoms, and there's a period of time setting where, for example, they may be diagnosed with colon cancer. Currently, we're not able to look at that time from the symptoms to the diagnosis, because the systems just aren't joined up across general practice and acute. We've also seen examples here in London that linked GP data has improved diagnosis and prescribing. And there's also been evidence previously of drugs such as Vioxx effective anti-arthritis drug that increase the risk of heart disease or heart attack. It took years to identify that association, but with linked data, with connections much more quickly. So how will the first phase work? Well, what we're looking to do, and we've got the mandate to do as part of the Care.Data programme, is to link data from general practice to hospital episode statistics. So what that would involve would be taking coded information from the GP practice, so for example, information like the NHS number, date of birth, gender, and we would be linking that to hospital episode statistic information from the health and social care information, where that information is then pseudonymised. All the identifying information is removed, and then that information would be made available at a very high level in publications, and then at a more detailed level to NHS England analysts, to analysts within clinical commission groups, and to public health. We also put on there, and I think it's important to say this is something that we're looking to do over time. Currently, health service researchers and analysts haven't got the appropriate permissions to access that information. So just to provide a little bit of background on what data would be extracted. So where a patient's visited a GP practice in 4 months prior to the first extraction, we'd be providing information on demographics. So as I mentioned already, things like the NHS number, date of birth, gender, postcode, administrative information, so encounters, referrals, and then clinical information such as diagnosis, family history, smoking status, observations. So it's important to say that the extract contains coded information, so it's not free text. So if a GP assesses a patient and records that Deirdre has presented with these symptoms and this is more information about it, that sort of information is not going to go as free text. It's much more about the coded information that's going in. So data which won't be extracted, so that contains codes that relate to sensitive information, so things like sexually transmitted infections such as HIV and AIDS, termination of pregnancy, IVS treatment, marital status, complaints, convictions and imprisonment, and domestic violence and abuse. One of the things that we've heard from recent engagements is that people really want to know what safeguards are in place. So on information governance, there is a statutory basis under the Health and Social Care Act 2012 for sharing information to better track outcomes across the health and care service. And that enables the Health and Social Care Information Centre to collect data when directed to do so by NHS England and the Department of Health. That does not, however, change the requirement for fair processing under the Data Protection Act. So patients still need to understand what data is being shared and who's going to have access to that and what their options are around that information being released or not. General practices are the data controllers for GP data and hold responsibility for fair processing. However, that's obviously supported by the programme. On extract governance, the data set for linking the GP data to the hospital episode statistics, that was agreed. General Practitioners Committee and the Royal College of General Practitioners representatives. The General Practice Extraction Service Independent Advisory Group recommended the submission for extract, and any changes to the actual specification would need to go through the same rigorous review. Opting out, obviously something that people want to know about. Patients can object to their data being shared in 2 ways. So they can object in general for data leaving their general practice for Care.Data. What they can also do is object to identifiable data about them being released from the Health and Social Care Information Centre. So some of you will be aware that in January there was an announcement that there would be an extension to Care.Data, and that period would enable us to listen to the views of clinicians, of patients, and a wide range of other stakeholder groups, really to understand the concerns and the views and to use that to shape how Care.Data should move forward. So we've now engaged with over, almost 3,000 people across 145 regional and local events. That's included patients, members of the public, GPs, practice managers and patients groups. We've also actively engaged with Health Watch England, the British Medical Association, Royal College of General Practitioners, charities, research communities, critical parts at regular intervals. And that's helped us to start to act on some of that feedback and help to shape the future direction of the programme. So what do people tell us? So the big concerns that people have, and they want to know more about the information on risks and the benefits of information sharing. They want to know how to object to sharing data, so that's both the processes and what's involved. They want to know who will receive the data and why, and what that data will be used for. They want to know why information that can identify people potentially is being used, and they also want reassurance about the controls and the data protection. Another thing that really was clear from the engagement over the last few months is that people are concerned around the level of engagement that's taken place up to January and also the speed of rollout. And in response to that, the programme, with support from other partners and stakeholders, has agreed to a phased introduction of Care.Data. and also for a full evaluation ahead of any further rollout. So the first stage will be to work with up to 500 GP practices across between 2 to 4 clinical commissioning group, what we call pathfinders. That's going to take place from now through to the end of the year, and that will enable us to evaluate and test and refine materials in conjunction with the practices, their local partners, and other stakeholders before there is any further rollout. And that's not just testing materials, that's testing communication approaches, seeing what works, that's testing the opt-out process, making sure that works, and that's also testing some of the technical processes like the extraction from general practices. So as you can see, it's a really, really key piece of the jigsaw in helping us to move forward. We're also working with a market research agency, company called Ipsos Mori, that some of you will be aware of. That's going to be through the Pathfinder stage, and that will help us to test opinion from both professionals and from the public, and that will also help us to inform the future direction of the programme. Some other important points on the Care.Data Pathfinder stage: patients can opt out and change their mind at any time around participating in Care.Data. We'll continue to work with key stakeholders to improve awareness and understanding of Care.Data through that period, and that's both at a national level, but commissioning groups, local health watch groups, public and patient groups, and all the local groups that are supporting practices. We'll also continue to work very closely with the BMA, with the Royal College of GPs, with Health Watch England, and with other stakeholders to address the concerns. I think the final 2 slides, just a little bit about what else has happened over the last few months. New legislation's come in to prevent the Health and Social Care Information Centre from disseminating information or certain other information where there is not a clear purpose for the provision of healthcare or adult social care or the promotion of health. Advice and scrutiny on the release of identifiable data will be provided by the Confidentiality Advisory Group, which is completely separate from the programme and the Health and Social Care Information Centre. It's an advisory group that advises on the release of data for medical purposes, and they've been appointed by the Health Research Agency. And those who misuse data will not be allowed to receive further data. So effectively 1 strike and you're out. Other progress: there's also been secondary legislation to bind the Health and Social Care Information Centre to protect individuals' confidentiality when anonymised data is released. And what we need to do within the Health and Social Care Centre is also to make sure we're abiding by the strict code of practice that the Information Commissioner's Office has around the use of anonymised data. There's also been a number of directions to the Health and Social Care Information Centre confirming that on a legal basis, if a patient objects to data being shared for Care.Data, that will be respected, and if they object, their data will not flow from the Health and Social Care Information Centre. We've also been working on a secure data facility, and that will give controlled access to data with only authorised aggregate anonymised data taken out of the facility. So, for example, just an example of the type of access, people who have access to that facility will have a swipe card to actually get into that facility, so that will be tracked and monitored. Opt-out also have to have a legal basis through directions through to the Health and Social Care Information Centre. So there is more information available. We have a patient line. We also have an email address people can contact with us by, and there's also lots of information on the website. Thank you.
So that's the pitch from the project team.
Kieran, microphone.
Yeah. Okay, so that's the pitch from the project team. We're going to take maybe half an hour just to what you think. We can go into more detail on anything you're interested in or concerned about or want to know more of. Yeah, the slides will be available. Absolutely. Hi.
Before there was the present world of Health Watch, there was the link. Before the link, there were the patients' forums, and before that, there were the community health councils. But in the course of that, somewhere along the line, there was a small survey group which I belonged to, and it arrived at the conclusion that confidentiality simply could not be kept at a worthwhile cost. I'm glad to see that this recognises that information and does have the assumption that there will possibly be leakages, hence the telling people that misuse of data will put them out of business. Good. The question that isn't there is what happens if too many people opt out. There's a level of significance somewhere that is breached if the level of opting out arose above a certain. What is it? So I leave that thought
and where
with you.
might
you
that
may
be?
Not know, but somebody knows and is not telling us.
Is that a Sam question?
I was going to ask exactly the same question about will we be able to know, I work in public health, the proportion of people that will be opting out. So if we're looking at data on a specific condition, how will we know, or will we be able to know the proportion of patients that are opting out?
Yeah. The answer might be just beside you.
I like questions like that one. The answer is yes. So HSCIC will be able to publish at a CCG level roughly what percentages are opted out. And I think that's sort of important because a 0 opt-out says that something went wrong. 100% opt-out says something else went wrong, which is, nobody agrees on this everywhere. So, if there's, and that's sort of part of that. And you can then look at aggregated stats from GPs that say this is what the counts are. And if you have access to the data in the secure facility, you can produce a similar count, which you can then extract. And if the numbers are massively different, you know that you have a disproportionate opt-out or a disproportionate not opt-out or disproportionate opt-in, and take account of that based on your area, your condition. And that's something that statisticians do routinely. If you're doing a survey, you test it against the population because that's what the census is for. And so there are a bunch of things that you can do routinely. It's a bit of work, but it does mean that you actually get the data. Going to the question about how much opt-in or opt-out is enough, how many people involved are enough, if you ask the Director of Patients and Information at NHS England, there is no limit at which this becomes useless in terms of opt-out. I'm not sure many people necessarily agree with that, but it's a case of what are the other data sets that can do this? And there are some that do bits of it, but their CPRD, which is the big research database, is 10% of the country. If you're bigger than that, it's better than anything else. That may not be a justification to do it. That may not be worth the effort, but there is at least a conversation that should be had, and we would be very keen for it to be had, and your question is an important one. Whether that conversation will be had is a question back to NHS England.
Yeah. Don't know why he was looking at me there. But the one conversation I was part of around that was saying the answer will be different depending on your research question or what you're trying to achieve. In some places, actually, if you've got 50% of people, you probably have a big enough sample. In other places, for other research questions, actually, you need it to be 90%. And rather than saying there's a level, it's saying let's do as good a job as possible, and then the research question you have will determine what level of confidence and what level of checking with other things you can have. That was the best answer I was given. Well, gentleman here.
Yes, I'd like to ask, why has there been so little information about the Pathfinder stage? Who are the groups? How are the groups chosen? How do you know that 4 CCGs is going to be sufficiently representative? What sort of questions are Ipsos Mori going to put in what kind of inquiry framework?
I can answer a bit of that from what I know. They haven't been chosen. No, they haven't been chosen, so it doesn't. They're talking to people at the moment and saying, do you want to, and so on. So that.
If you're not talking into a microphone, we can't pick you up on the webcast. So if you could just let Kieran respond, that would be really helpful.
So they hadn't started. What the 2 or the 4 CCGs will demonstrate, it'll demonstrate 2 things. The first one is this process technically as secure as possible? Conversation that a few of us were part of over the last week, we were saying, well, it would be very interesting to know, even for those 2 CCGs or 4 CCGs, are we able to demonstrate benefit? Not just we can technically do this, but are we able to look in and say, I don't know, maybe it's a question about diagnosis of colorectal cancer. When we did see, the primary care data beside the hospital data, we saw something we didn't see before. So we quite liked that idea, but nobody started because they haven't been selected. But I know they're trying to. There was a meeting in the last couple of weeks, which didn't seem to, I think they're in the middle of the process.
I can give a little bit of a further update. So we've got a selection panel, which comprises of representatives from the Royal College of GPs, from BMA, from Healthwatch England, and also from patient representative groups. They considered some expressions of interest from a number of CCGs that they were hoping to make a decision last week on selecting the pathfinders that they wanted to participate in this pathfinder stage. There was a little bit more information that they want to investigate with a couple of those, and that's happened this week. So we're looking to reconvene that panel next week. So we're hopeful that following that panel meeting, they'll make a decision, and that will be the decision will be confirmed a few days after that. So I think we are moving forward. One bit of clarification it's worth providing is initially we were looking to go out to write to all CCGs across the country to invite them to take part. I think we had some input and advice on that in that I think quite a lot of people felt that if we did that might be a little bit cumbersome on CCGs in the current environment. And if, for example, we had 50 CCGs apply and wanted to take part, and we could only select 2 to 4, that might not be the most appropriate thing to do. So what we've done is we've continued engagement with CCGs across the country who, during the engagement activity over the last few months, they expressed some informal interest in being pathfinders. And what we've done is we've had some more discussions with them, and the ones that have gone through to the panel are a number of those CCGs. What we wanted to do as part of that discussion was to make sure that they were aware of both the benefits and the resource pressures on being a pathfinder, so that they can make a really informed decision before going to the panel. Obviously, we don't want the projects to start and then them to feel as though actually this is too much for us. So that's where we are. But that doesn't exclude other areas of the country taking part in the Pathfinder stage. So it may actually be beneficial actually to test some materials out or to test some sort of approaches with other practices across the country. So even if a CCG doesn't want to actually be a Pathfinder area, it may well be that some practices do want to participate in some way. So we would say that all options are on the table on that respect.
Is that okay? Gentleman here.
Can I just come in with a question that came up on Twitter, and it came up in Peterborough as well, so I'm going to look to colleagues who might be able to answer it, is whether or not those seeking gender reassignment surgery or those who've gone through gender reassignment, whether their data would be excluded from the extraction.
I don't know the answer to that. Yep, you.
Yeah, it's absolutely one to come back to you.
Okay, so we note that one, and we absolutely need an answer to that.
Can I make an editorial comment? One of the things which was on the slide was that HIV diagnoses are excluded. And another thing that was on the slide was that the data that would be extracted was a group of, BMA, Royal College of General Practitioners. If you're at the Terence Higgins Trust, you're not entirely happy with that decision, because the decision, A, wasn't made with a patient group, who are the people who would know, and the second one is they're not really entirely happy with the decision itself either, because they want to know how many people have HIV as well. So there's something in this process that should not be, I'm sure the BMA and the Royal College of GPs were making very good recommendations from their point of view. But there's a lesson I think we feel fairly strongly about is none of these big decisions about what's in, what's out, what happens should be made by one particular point of view, be it a clinical point of view or a commissioning point of view or a patient's view exclusively as well. We need everybody in the room. So I think a number of us feel there was a kind of a process failure there as well, which we're hoping won't happen again.
Okay.
Rachel Weems from Friends, Families and Travellers. It's really good to hear that the opt-out will have a legal basis and the GPs, surgeries will be the data controllers. If someone's a nomadic traveller or has no fixed abode, and they might be accessing lots of different GP surgeries across the country on a temporary basis, will they have to opt out every time when they register at a new GP surgery?
I think it's a really good question. I don't have the answer. I don't know whether any colleagues...
I'm from NHS England, by the way. I'm Robin Burgess. Strictly speaking, once the code's been put in, it should be registered, as I understand it, by the information centre and block flows of data from any individual, whether they go to any practice. That's my understanding, but it really is a technical question for the Health and Social Care Information Centre to answer.
Yeah, that was my understanding too. It's you who opts out. It's your NHS number that opts out, I believe. There's a gentleman here as well at some point.
It was a follow-up question. The follow-up question to the one around the pathfinders, and it's just to know what ongoing communication plans are for the public so they know when it's an appropriate time for them to be making the decision about opting out if that's what they want to do.
Great question.
Yeah, again, a really good question. I think what we've said and what we've been advised to do by the advisory group and by our programme board is to use the Pathfinder stage really to determine kind of what happens next. So what we can't do is say now how quickly Care.Data will be rolled out across all GP practices following the Pathfinder stage. We really kind of need to get in there, and we need the absolute feedback from local groups supporting the CCGs and the practices. We need the feedback from the practices, from the CCGs, really to get their view on what works well, what's maybe not worked as well, and what we need to do to improve things. And no, I mean, I should also make clear that extraction of that data from those practices won't be, the decision won't be taken until the right information has been made available, and there'll be a full valuation, independent evaluation after the Pathfinder stage, really to determine what happens next. And so.
Yeah, and my understanding is one of the things which will be tested will be different types of communication from maybe different CCGs or different parts of the geography. The one thing we know is a door drop that nobody ever sees, because I know I didn't. That doesn't work, but maybe. So we need to test that. I think as part of the Pathfinders and see what works. And one of the things back to Ipsos, one of the things they'll be testing, understand is, in this thing, how many people actually understood this was going on, and whether there was a different communication approach. Did more people or fewer people understand what was going on? My understanding is that's the intention.
Just to add on to that, we're also committed, and this does fall to Ruth and I, to help facilitate to working with the local Health Watch and other organisations where those pathfinders are, to work with them around how do we co-produce materials that are appropriate to those communities, what's working, what's not working, so that we're not producing something in the centre that actually nobody then reads or understands or can connect with, that we're doing that as locally appropriately as we can.
Yep. Great.
Maybe a slightly stupid question, but have any or many surveys or research been done on people who have opted out?
I don't know. I think somebody knows. There was some practice where a lot of people opted out and some where almost nobody opted out as well, but I don't know. I'm just looking at Sam here because he knows this kind of stuff.
The short answer to that question is no. Because it is all held at a GP practice level. It is not yet. HSCIC cannot tell you how many people opted out throughout the country. In October, when they take the lists of who has opted out of the hospital episode statistics and take that up, they'll be able to give that figure, and that figure is pretty much the same as the one who've opted out of Care.Data. And so there'll be then some sort of figure. Various press have phoned 30 GPs and ask for a rough figure, and we have figures that go up to 20% just off that. Whether that is accurate or representative, we have no idea. And going back to the person on the next table's question about the Pathfinders, there were a few things that came up in this presentation that I hadn't seen before, and one of them was that the Pathfinders will now certainly be running into November, which was news to me. So that's sort of, there are things that are changing without being said they're changing. And to the question about travellers and home practice, about travellers, your home practice, whatever that means in a traveller setting, if it means anything at all, is the one where you have to opt out, not a temporary practice. How that works, I have no idea. But NHS England should probably give you an answer.
Which I'm sure they will. Lady there.
Okay,
Thank you.
Abby May, I'm from Healthwatch Stoke-on-Trent. And what we're finding is that people simply don't understand what Care.Data is. Putting simply, it sounds really good. It sounds like if I get knocked over by a car and I go to the A&E, this means that they'll be able to access my GP records. I would say that that's what the average person who's not involved in anything with medical, no professionals, that's what they understand. And therefore it seems rather unfair that we're expecting people to opt out when they don't understand what it is that's going on. They think this is to do with my care. So I don't think the message has got across. We had actually a public meeting organised by, I think, NHS England in Stoke. And out of that meeting afterwards, 90% of the attendees still had questions that they felt had not been answered.
Yeah.
So, and those are people who are engaged with the subject. But if you actually go then to your local GP practice and sit around, there's no signs up. There's no, and even if there were signs up, there's accessibility issues for people that have limited education, disabilities. Have you considered all of this? And have you really seriously considered turning it around and making it an opt-in?
Yeah. The start of the end, the consensus is it's not opt-in. And because that goes back to this, you know, if you have to get 50 million people in the country to turn up to sign a form to say they're opting in, it won't work, and it definitely will not deliver the percentage. So, and the Information Commissioner is broadly comfortable with that, as long as everything you've described is addressed. The idea that people can be genuinely make an informed decision not to opt out or whatever, if they don't know what it is or if it's confused with something else. The second issue is, we were chatting outside around, you know, there's this summary care record project going on. This is part of a much bigger question. You know, the Care.Data thing is about linking primary care database into the information centre. There are lots of other things out there as well. What about social care information? So the communication to the public, if we're only communicating about this little bit down here and we're not communicating about the big message, then I think the comms wouldn't be right. So I think your salutary warning, so to speak, is absolutely spot on. And back to the comms testing in the Pathfinders, it has to be which methods work. Something on a notice board in a GP, I mean, I happen to have been to my GP in the last 2 weeks, but I hadn't been for the previous 5 years. God knows what was on the notice board. I'm certainly not going to know about it. So I need a different form of communication. So we have to do all of that, and that needs to be tested in the Pathfinders for exactly the reasons you say. Don't know. There's a lady here, gentleman there. Oh, sorry, after you.
So I'm Jeremy Burden from South East Commissioning Support. So it builds on the question previously. There's a lot being asked of GPs just at a time when their national share of the NHS budget has shrunk, just at a time when the system's under tremendous pressure within primary care. I suppose my question is, what safeguards, what confidence levels do you have that general practice, and I'm talking about the practice as a whole, not just the GP, but the general practice as a whole will be able to deliver this in a consistent way that gives confidence that when people have opted out, that they are fully informed, that the processes that have been through for them to make that decision at the practice level have been robust. And I haven't seen that really addressed, other than the Royal College of GPs have all signed up in terms of what the extraction will be.
See what other people think. My answer is until we've actually tried it in real CCGs and real practices, nobody can say that. And I think that was one of the issues earlier. When people started asking intelligent questions exactly like that one, the answer was, don't know the answer to that. So, and we, I think to say absolutely we know how these processes will work would be wrong until somebody's actually gone out and tried it and said, actually, this didn't work. So, and that's why I think these Pathfinder things, there's no rush with this. It's more important we do slow and steady, I think, than it is that we sort of get stuff out there. So I think we bide our time, we see what we learn here, we pay attention to what we've really felt like on the ground, as opposed to when we're, whoever we are, sitting sort of with a pen and a piece of paper dreaming up good ideas. So I think we can't answer that question because nobody's actually ever done it.
But just to add that, assessing the burden on GP practices and helping to make sure we reduce that to the absolute minimum to support practices to be able to meet their obligations in terms of fair processing, making sure that when a patient presents at a GP practice, we need to make sure the information's there. But that's really, really part of the Pathfinder stage. We've just got to get that piece right, and we can't do that just sitting at the centre. We've got to get down onto the ground and get that feedback from those Pathfinders to find out what works and how we can make things work in the best possible way locally.
Can we go one and then two?
Yes, I just wanted to say that I think Care.Data is such a logical, wonderful idea. Perhaps we should be wondering why we haven't done it sooner. However, the big thing is, I think, a problem of trust, because people are fearful of their data being sent to people that shouldn't have it. And in some ways, the genie's out the bottle already, because the Children and Families Act already gives authority for personal data to be shared for research purposes. And also the Care Act, when it comes out, as you've already said, the information can be shared for public health, I think it was, promotion of health. So already there's some difficulty wondering actually how the data is going to be kept secure and not provided to people who perhaps are, wanting the information for
other commercial, whatever reasons. That. Do we want to answer that? Do you want to have a go, or shall I?
Well, I can. I mean, there's a massive amount of work that's been going on, particularly within the Health and Social Care Information Centre. So you might know that a chap called Sir Nick Partridge has done a review into data releases, and I think we've done an awful lot of work in really kind of sharpening our act and making sure that we've got the right controls in place. So I mentioned about the secure data facility. That's one example of making sure that we do everything we can to minimise the wrong information going to the wrong people. But it's fundamentally at the heart of what we're doing. We recognise that even with pseudonymised data, there are ways and means, or however unlikely, to actually identify those individuals, but we're doing absolutely everything we can to prevent that from happening. And obviously, there are, if that does happen, there obviously are criminal and financial proceedings you can take against any organisations or individuals that are, all that unscrupulous to actually get involved in that activity.
Okay, where shall we go? If we go 1, 2, 3, 4, and I think with a hand up there.
My name is Sharif from Health Watch Sutton. A lot of work has been already done about the care. I think it's about a couple of years ago, 55 plus people who were selected throughout the country, and they were selected for, I think to find out whether they've got any kind of a bowel cancer and things. And I'm not sure about the whole data, but that data was protected because, including my GP has got that data. So that's the best example already exists. So why don't we practice what the good practices already exist, and based on that? Sorry.
Yes, I think is the answer to that. In my world, in cancer bit, I probably know a bit about the data. There's the GP research database, GPRD, which does exist, which is the 10% of the country, it is not linked to the hospital episodes data, which exists broadly everywhere, and it's making that connection. So we can tell you a lot about what happened to colorectal cancer patients in hospital, but we don't know what happened in primary care and whether that had a good or bad effect on survival, and that's the kind of the benefit. But there is a lot of good practice there. But one of the things I think the stumble, whatever phrase earlier in the year showed, actually that some of the protections that we expect as the population today may not be as robust as they need to be and have not been as robust as they need to be in the past. So there's a bit of catching up that this has exposed, which is one of the reasons, personally, I think this slow and steady. So there's absolutely brilliant practice out there, but there was some kind of less than brilliant practice too, which this has exposed, which also needs to be fixed, which will also take time. If that's okay. Thanks, Sharif. Hi.
Hi, Linda Damerel from Tapestry Innovation. I'm interested in the voluntary sector and social enterprises involved in service delivery, maybe social prescribing. How are they going to be asked to capture data and feed that into the system? And is that going to work strategically at a neighbourhood level? Because I was at another NHS England event this week where GPs are proactively looking for support from their local third sector. So with the Pathfinder opportunity, there's an opportunity to bring in the third sector with that piece of testing.
Yeah, I mean, absolutely. I mean, we absolutely fully support practices actually kind of engaging with any support networks that are out within their local communities and understanding what, how they want to shape Care.Data as they move forward. I mean, in terms of the data set that's been agreed by already, there's obviously nothing else we can kind of do to bring more information into that one, but obviously we do want to make sure that we're looking across the spectrum in terms of kind of looking at what other information would be useful to bring in and how that should be linked to various other data sets. So I can't answer specifically what's happening in your area and what kind of engagement's been made, but I would really welcome both engagement with your local practices, with the CCGs, but also directly with our programme as well to understand what your requirements are.
And one of the things we're saying as the advisory group is that the comms in the Pathfinders or elsewhere needs to be positioning the bigger picture, not just we're going to be linking this data from your GP practice to there. It has to be the full conversation with the public, not this little bit. And I think that's important. Who have I missed?
I noticed that you are also going to be collecting data from the ambulance service. How on earth is a patient going to be able to opt out from the ambulance service, especially if they are in a different part of the country and they have a fall and they're taken by ambulance to a local hospital?
So, I mean, I can say our ambition is to actually provide more linked data across different care settings. But obviously our focus at the moment is working through quite a challenge, clearly, in linking GP practice data with hospital episode statistics. That there's no ambulance data set piece of work that's been commissioned. We don't have the mandate for doing that, but obviously we do need to take into account all the challenges around that if we do find that there is a need and a requirement to actually do something in the ambulance sector.
But if you opt out of everything, I think is my understanding. So it's your NHS number which is blocked, I think.
Does that include HES data? Does that include HES data too?
I think if you opt out, and that will include opting out of having your HES data shared, I think.
So there was a slide on that I went through that talks about you've got two options. One is to opt out of your data leaving your general practice, and then the other one is to opt out of any data leaving the Health and Social Care Information Centre. So on the second regard, that would mean that no, it wouldn't be included.
Can you just be a little bit clearer here about some of this debate? We need to be absolutely clear about two different types of uses of data within the NHS. The first of these is the primary use of data, which is where data is shared for the purposes of your immediate care. And data in relation to the ambulance service, for example, would be used primarily for that purpose. And Care.Data is not concerned with that. Care.Data is concerned with secondary uses of data, which is about research, audit, long-term service planning and monitoring, and so on. So opt-outs that apply to the sharing of data for primary uses, things like that relate to the summary care record, are quite different to opt-outs that relate to the flows of secondary data. The long-term intention of Care.Data is that gradually more and more data sets would be included from a variety of different settings, including, hopefully, at some point in the future, social care data, community data, as well as GP data and existing hospital data, which has been flowing, as David said, for some 30 years. At the moment, the only mechanism to block that is for you to register your opt-out through your GP to cover the two existing flows that we're talking about here, primary care data and data from hospitals. So if you register both, then data that could flow from a hospital would then stop flowing, as it were. If you don't register your data, though, through your GP practice, data from the hospital will still flow. However, in the future, our plan is to simplify the whole opt-out process so that it is much clearer what it will cover. But in the second part of this workshop today, there will be one session which will really focus upon opt-out, and you can make all those points then, and we can register those and use that to influence future design.
Thank you. That was very helpful. Gentlemen.
Do you want? Okay. Jan? I think it's your turn. Jen.
Jen Person. Just to come back to Abby's point of the clarity around what is Care.Data, I just wanted to come back to the communications, in that for the Pathfinders today, we're talking about how we'll be testing current communications around what is Care.Data and how those Pathfinders might inform future communications. But I wonder if NHS England could also address the future scope ahead of this, because at the moment there's not only a shifting uncertainty of what is included in Care.Data, but also in terms of the landscape of NHS. So come April, police custodial health, sexual assault centres health is going to be taken on by NHS England. There's an increasing, as Robin Burgess said, an increasing incremental adding to the types of data that will be held. And for those people that opt in, to come back to your point on public health research, if you want to have a really high rate of opt-in, people need to know what they're opting into. And I worry that the Pathfinder's scope of communications is very much focused on the today and the now, and is not addressing how will scope change of what is taken up in future and who will have access to it, and how will people know that what they opt into today stays what they've opted into in the future.
Yeah, and I think the advisory group's advice is to do exactly that as well. Can we just do one and then two, because you've both been very patient?
Sometimes the dangers to the database are not obvious. One of the whistleblowers in America was one out of approximately 1 million people who had the same information. Anybody who decided that was stupid in not realizing what was going to happen. What is difficult is if you have a wave of publicity about somebody prominent, a singer perhaps, that is widely known, and that causes enough people to think about their own medical record and whether it should be as easily available as it is. And you can't tell in advance how that will happen.
And I think there is a table going to be thinking about the secure data facility, but a couple of us were at a meeting last week where you have to be an approved person to get into that room, and it will be a room with a security guard and bars on the windows. You have a time-limited amount. You cannot take anything out of that room with you. if you try and take the hard drive out of the computer, actually the data isn't on the hard drive, it's a dumb terminal. So there will be lots of physical protection around this as well. So it won't be that there'll be sort of emails pinging around with data sets on them. You know, certainly in the early days, you will physically have to go to the information centre to do your research. So I think one of the tables will be picking that up, I think. But for exactly that reason, you know, the Office of National Statistics do this kind of stuff, you know, so there is, back to good practice, there's good practice we can learn from and make sure we get it right for exactly that reason. And if that's done well, it's more secure than the thing at the moment where there are lots of paper records in a GP surgery, and if somebody broke in, they could walk out with a file under their arm. So we need to kind of think all of that through. So I agree with that. Gentleman here.
Yes, I wanted to come back again to communication. I come from Milton Keynes Health Watch, and I also chair a local PPG. I've moderated a couple of PPG network events on Care.Data and talked a lot in the PPG. And in general, I've had a very, very negative reaction in both sets of discussions. Now, I think part of the reason for that is the original launch was generally considered a disaster. The video we saw and the leaflet distribution, etc., junk mail, all the things that have been noted. But the problem is, I think then, is that when you get to the Pathfinder stage, you're not really starting from a level playing field. In a sense, you're starting way behind point zero. And from that point of view, I think it's very important in the Pathfinder stage that the communication people are included in the very original design of the Ipsos Mori, because unless you get the survey questions right, you won't get any kind of segmented communication strategy right.
Yeah, take that on board.
Totally agree. We're going to have to bring this bit to a
Thank
close.
you for that.
And they've been really fantastic questions. We will be able to respond. So the questions we haven't answered are the questions that need to be asked because nobody knows the answers. Well, nobody in this room at this point in time anyway. So certainly the one around travellers and that registration one needs to be clarified, and the gender reassignment one needs to be clarified. Yep. So we will get those out, and we'll try and get, if they can be clarified, they'll be clarified in the report we write up post this event. So we're going to move into tabletop discussions. We're going to let you get a cup of coffee or a cup of tea before that. But just so you know, so we're going to split you up into 3 different conversations, and then a random 4th conversation if you don't want to talk about any of those 3. So we're quite happy that you self-choose and decide what you want to talk about. But when you come back from getting your coffee, if you want to talk about making informed choices, so how do people have the right information at the right time, in the right place, in the right format to make a choice in an informed way, come and sit on table 1 or table 2 over here. Okay? If you want to talk about the security, the confidentiality and the access issues, come and sit on tables 3 or 4 here. And if you want to talk about the data and the methods of collection, come and sit on tables 5 and 6 here. If you want to have a nosy, there's some prompt sheets on the tables. They're based on the things we've heard so far. They're based on the issues that people are raising and the things we know are being discussed. You don't have to be limited by that. So if you want to be the radicals who go, actually, I don't want to talk about any of that, come and sit over here and determine what you want to talk about, particularly if those things aren't answering the questions that you want to bring to this. There will be facilitators, there will be scribes, there are cards to write stuff down on. And if you do not want to be webcast, we're not filming you, and you sat on this table here, you can choose to throw your issues over to those groups as well if you want by writing them on cards. Okay? Is that helpful?
Yeah, and the webcast is switching off at this point.
Yeah, the webcast, it doesn't work. Sorry guys if you're watching on the webcast. It doesn't work, webcasting tabletop discussions, because it's just too noisy and you won't be able to hear. You'll just be able to see a room full of people sort of mumbling and drinking tea and coffee. So thank you very much for watching on the webcast. We will clock back into the webcast. So we'll prompt and we'll tell you on Twitter when we're coming back online. Okay? Thank you.
Thank you, everyone.
that your feedback's going to be as crunchy as it can be. Earlier on. We've got some weird feedback thing going on with the microphones as well. They're whistly. So, we don't really want to do death by feedback, but what we'd really like is really crunchy stuff. So, I suppose what I'm asking is, as the table discussions, you're now speaking to the advisory group. You're saying to the advisory group, this is what we talked about, and these are the things we want you to go away with, to talk to NHS England more about, and this is the progress we'd like to see, this is what we'd like to see happen, or this is the thing that, for us, is a real sticker. Go away and have some real big brain conversations about it and see what you can do. Is that okay? But I don't want a reiteration of the last half an hour's conversation, if that's all right, because we won't have time. And welcome back to everybody watching on the webcast and back on Twitter. We'll try and bring some of those things in. Ruth's been tweeting away madly. We'll try and bring some of those things in as we do the feedback. So if we go to tables 1 or 2 first, who were talking about how we make informed choices and what we need to do. Who would like to go? Beverly, have they left you to do the feedback?
Yeah, but they said they'd help if I got it wrong. So I'm just going to start and see what you reckon. Okay, people still don't know the basics of Care.Data. So really clear basic information is still needed. We need lots of front doors for this, not just to rely on GPs. Lots and lots of front doors, and we had lots of examples, local free newspapers, libraries, carers centres, CCGs, voluntary groups, Marks and Spencer's, creative, we said. And then we said, in order to be creative, you've got to think outside the box about all those different front doors. Is that okay?
Cool, thank you very much. Anything from this table that adds to that?
It's really important to be honest about the difference between Care.Data and summary care records, and to be clear about the risks and benefits of data sharing. We also had some conversations about reaching older people and the conversation not just being online or the information being online. Is there anything else?
I think you kind of touched on this, but about facilitating discussion and not just providing a leaflet or, some frequently asked questions, but allowing people to have the opportunity to discuss the topic with somebody. So, like the other table said, kind of community groups and that kind of thing, facilitating those discussions.
Cool, thank you. So, of the other tables, are there anything around making informed choices that you would want to add to that as feedback in terms of what you think needs to be taken on board or taken into account? So it's about the right communication, the right place at the right time through diverse means, thinking outside the box, being more innovative and creative and going to where people are instead of expecting people to pick it up in their GP surgery. Using language they understand, and that came through on Twitter really clearly, that following the Twitter conversation today, it's full of acronyms and jargon and nobody really knows what we're talking about because it's kept to the health elite who understand the health jargon. I'm struggling myself. Robin.
Our table particularly focused upon the needs of those with learning disabilities, and really stressed the need for a wide diversity of communication methods to reach that particular group, because enabling them to make a really informed choice is very much about working with their advocates, with those who have power of attorney, that's something I was thinking of. Yeah, all those kind of things. So that's what we wanted to add.
Yeah, and again, thank you. That came through very clearly on Twitter about people who need additional support to make an informed choice. How are they going to access that? How are we supporting them to make their own choices in an appropriate way and a safe way? Thank you. Okay. Table 4, instead of having 2 tables, you were rebellious. So we've got one table who talked about security, confidentiality and access. Who's going to do your feedback? Really unfair.
Okay, that wasn't in the script. Not to worry. Okay, so people are the weakest link in any system. So I think less concerned about the technical vulnerabilities, but in terms of individuals having access to the information and using that in an appropriate way. Also wanted to know what legislation will effectively cover how individual act and who has access to this. So one example we gave was on any qualified providers. If you've got a commercial organisation that wins a contract to be a provider of services, they might use that information in an appropriate way to help plan the services, but they might also use it for commercial gain. So really wanted to find out what preventative measures prevented them from using it in an appropriate way. Another one was, in principle, Care.Data is a great idea, but some of participants weren't convinced enough around the safeguards, and it's a place to keep data safe. Another one was, how do you define one strike and you're out? So if an organisation does use information in an appropriate way, that organisation may no longer have access to the data, but there might not be anything to stop them setting up as another organisation and doing the same thing again. So there were some concerns about that. There was a question around the opt-out fields, how visible they would be. So, for example, if patients had access to their GP record, we're obviously aware of the work going on to make general practice records available to patients next year. Would it be possible for patients to see if they are opted out of something like Care.Data, and obviously if they wanted to change that in the future, how easy would that be for them to do? There were some concerns raised around the pressures on GP practices for opting out. So in principle, a patient phoning a general practice and speaking to the receptionist or a practice manager to say they want to opt out is all well and good, but that might be not something that general practice have got the capacity to do, and it might be very difficult, complex, so it might be better to have some form of website where people can opt out as one option. Also, what's the plans for the worst case scenario? So if lots of data did get out on patient level information, what would be the impact of that? Also need assurances around non-commercial uses. So I think that links back to an earlier point we were making around information being used for inappropriate ways and non-commissioning purposes. How will the Health and Social Care Information Centre oversee safety of data? Wanted a little bit more reassurance on that, and particular if any data was going to end up going to an organisation that might put that information overseas. Prohibitive penalties for misuse of data, so really understand a little bit more clearly what the penalties are, both the legal and the financial penalties. And I think there was a recognition that some of the financial penalties may not be as may not encourage organisation as much to avoid misusing data than they might if they were relatively low, given that some of the data may be very valuable and it might be worth some organisations taking a hit on that, which obviously is not appropriate. And then once information is left, sorry, this goes back to the earlier point around information going overseas and what legislation is in place to cover that information going to other countries. Don't know if anyone wants to add to any of that.
Would you like to answer some of those questions, Andrea?
Is that your work programme for the next couple of months?
I'll send an email.
Yeah.
Any questions from the rest of the room, just in terms of stuff around security that you don't feel was covered in that fairly extensive list of questions?
Just about how you would ensure that data had been destroyed when it was no longer being used.
Yeah. These are all questions we need to answer. I mean, we could try answering some of them now, but maybe if we write in the notes of this, we'll write what we have been told, or we will go and ask some of those questions, and we'll put that in the notes, if that's helpful. And then you can always come back and say, I believe it, I don't believe it, or that's enough, it's not enough, or whatever as well. But
what we'd like to be able to do with these questions is, in the post-event report, as Kieran says, write the questions out as you've described them, and then the response in terms of this is still a work in progress, but this is what we think at the moment, or this is the situation, so we get some clarification.
Yeah.
Okay?
And they'll all be on the website as well. Lady there as well.
Sorry.
Thank you. Is your data still available when you're dead? And is it used when you're dead?
Yes. And there's an interesting legal thing around that, is the privacy rules, of course, when you're dead change. I think they basically don't apply because so the rules do actually change, but absolutely, and that's part of the historical record as well. So yes.
Cool. Any more questions around or points that people want to log around that? Okay, we come to this table. So we had two tables talking about the methods of collection.
We were due to talk about data here and what type of data, what it will be used for, and so on. But I'm afraid we didn't stick to that remit. We talked about pretty much everything. So it's very difficult to give a comprehensive list. But essentially what we were discussing was there are a whole range of very technical questions about Care.Data that we need answers for and we need to communicate to people. We also cover the whole issue of records of people who are deceased, or indeed people who are living, who might be referred to within your family history for an individual who is within Care.Data, and so on. We talked about learning difficulties. We talked about the contrasting needs that public health have for greater granularity of data and other views about the desirability of all that. We talked about lots of issues to do with opt-out. We talked about the difficulties of a really informed consent and the needs for good communication. We talked about the need for a data quality strategy to be developed which supported the flow of good quality data into the system regardless of where it went afterwards, so we can make sure that what was in the data system was accurate. And then we talked about very, very serious issues of communication and understanding about pseudonymization, which we really do need to get clear. What it means, how safe pseudonymization is, there have been weakly and strongly pseudonymized data, the role of ashes, and so on and so on. We really haven't communicated this well. I'm not even sure that anybody really understands it properly. So these need to be really addressed.
Thank you very much for that.
Any more points to add from that group? Are you happy that Robin's done a good job? Fantastic. You were talking about the same conversation. Anything you want to add?
We were interested about whether the public would be able to see the data set that would be used to report against, and we were wondering whether there could be a layperson's version of that. We thought that every point of data that was being collected should be well being checked so that there was a clear reason why that data was being collected. We thought that was very important, that there needs to be absolute transparency as to why data is being collected. Data cannot be used for monetary gain. We also talked about that issue about a company being blacklisted and then reforming as something new and accessing the data again. And individuals as well, yes. We had a discussion about whether it would be useful for religion to be collected. We like the aspiration that one day data should be collected from all services, not just from GPs and hospitals. We felt that there had to be a balance between the level of detail that was collected and confidentiality. We felt that information about the whole scheme should be available to people at different levels of complexity, so that people who are really interested in the scheme could get detailed information about it, whereas people who just want to know the basics of it could access plain English versions of that. We talked about how the level of opt-out, particularly perhaps in a particular disadvantaged community, could skew the review of how services were commissioned in an area. And I think our last one says it's all about trust.
Thank you very much.
Anybody from other groups? Sorry, that group. Is that a good enough reflection of your conversation? Happy? Excellent. Anybody else want to add anything? No, so this is the anything else table now then. So this could be a little mystery tour of what it was you wanted to talk about, or whether you just wanted to have a natter about something completely different.
Yeah, we had a bit of a natter, actually.
Excellent. It's Saturday.
We did tour the subject area broadly, I think, across a whole range of areas. I'll try and pull together some of the big issues, and we actually had we tried to pull it together around our sticky question towards the end. We reiterated a lot of things that were mentioned in other groups, but there were some nuances here. We had a particular emphasis on transparency of the process and a bit of criticism of transparency, and things need to happen in order to make the process more transparent. So, for example, how are the pathfinders being identified? You know, are there going to be a range of pathfinders that come from both maybe a slightly negative perspective of this agenda and some that come from a positive? And how does that then sway the benefits that come out? Somebody from the NHS England team here to give feedback on some of the changes on this. So that was quite a big issue for us on this table. There was, we did focus on the information, but very much about the health workforce and how is the health workforce being brought forward on this as well and being better educated, and where is that to best sit? So more information, I think, for that workforce. And our sticky question was about what can we learn about data sharing generally from this process, and how does that apply in other settings? So there was quite a bit of discussion about actually what we're doing is creating a data sharing protocol for what exists now, when in the future, the future of health and social care is more about a range of providers, localised, transformed services, which are based on prevention. This data sharing is just about GPs and hospitals. It isn't fit for the future that we see for health and social care. So, and that's a fundamental flaw. And there were some issues about have we got the technological capacity at the front line to do this. So it was positive.
Apart from that, it's great.
But we got into some really quite deep issues, I think. Does anybody else on the table?
Just to add a couple of things. On the issue of the Pathfinders, one of the things that we discussed was the original intention, I know, was to send a letter to all CCGs, and as you explained, eventually you decided to find out the interest of CCGs in doing this. We wondered whether this wasn't actually going to bias your sample, because you've in fact got a positively inclined group of CCGs. I mean, in many cases, what you're trying to do in the pilot experiment is to see what happens when you've got a negatively inclined CCG. So that was one. The second thing was on the issue of trust and communication again. There was a certain level at which everybody needs to understand something, you know, right down at the level of the individual person. And there we thought it was important that the whole question of opt-ins and opt-outs was clarified. In my NPPG, we've had a lot of problems about the two levels of opt-out, and in fact it's taken more time to explain that than to discuss the entire question. But apart from that, there are many things that can't be understood, or people will want to understand at the individual level. Therefore, you were dependent on people in the community, opinion leaders in the community, being able to relay the essence of this. And there you've absolutely got to have the trust of those opinion leaders, and they have got to feel fully confident in it. Otherwise, the whole system disintegrates.
Yeah, and that gets back to this thing of layers of, if I just vaguely want to know about it, I go here. If I really want to understand it so I can talk and explain and sort of worry about it, then I want that extra level of data, and there's probably a third level as well. So I have a lot of sympathy for all of that.
Any other things from other tables around the room? Another one? Yeah, go for it.
Just picking up the point about, obviously, the wider agenda of bringing together health and social care is the work of the National Integration Pioneer sites, who are doing quite a significant piece of work on information sharing. And obviously there's some valuable lessons that's coming out from those various sites, and making sure that those sites are particularly used, particularly they may help with some of the discussion around identifying those Pathfinder, CCGs, GP practices, but also other more detailed work that's being looked at as part of not just care data, but the shared care record, and just making sure that that's taken into consideration.
Thanks.
Can I just come back to the point about the Pathfinder CCGs? One of the points that we were asked to include by, I'm not sure whether it was the advisory group or the programme board, was to make sure that we had CCGs and practices that were both actually pro Care.Data and some that had real concerns, because we recognised that actually just going to CCGs and practices that were all very, very happy about this wasn't going to be the right thing to do. So absolutely in the mix, and when the selection panel met last week, that was absolutely within something that was really on their mind. So they do want to make sure they're going to areas that are both pro and maybe have got concerns. But I think, as you probably, it's not a surprise to know that even within all the CCGs we're talking to at the moment, there's not one of them would say that actually all our practices are happy with this. So we recognise that there are going to be obviously a number of practices that aren't going to be happy with how things are moving forward, and it may well be that some practices within the CCGs actually don't want to take part in the Pathfinder stage, and nobody would say to them you have to take part. That's really that's really down to them whether they do or don't want to take part.
Robin wants to come in as well.
I think David's probably answered it in the last few minutes. I'm doing the engagement with CCGs in London as to whether they would be interested in being a Pathfinder. And in practice, it isn't really any indicator of whether they're a pro and con in any number in any particular area, just talking to the CCG, because it isn't them who are pro and it doesn't matter whether they're pro it or not pro it. What matters is what the GP practice thinks. And if a GP practice doesn't want to do it, they won't do it. As simple as that. The key thing we've got to do is get GPs on board to make sure they will support this. And there will be, if a CCG says, yeah, we're going to do this, there will be lots of naysayers amongst the GP community within those particular areas. So it will not be a skewed process. And no CCG, believe me, can make all its GPs within its area do as they are told. So it's not a, oh yes, well, we're only going to round up all the positive areas. That would be a ridiculous view of how local democracy works, really.
Thanks, Robin. Before we come to Kieran to wrap up, I'm interested to put Sam and Cynthia on the spot in terms of this as a conversation, how it resonates with what you've already been hearing as you've been talking in the advisory group. I suppose what the things are that you're going to go away with in your minds to think about. Who wants to, having put you on the spot, you're perfectly at liberty to refuse to talk, but I'm walking towards Sam, clearly.
I clearly have a reputation for talking too much. I think there have been apart from some of the new details in the presentation from HSCIC, there's been nothing from the floor that's not been said before. There are still no answers, but there haven't been a substantial number of new questions. It's sort of asked in a new way, asked about a new subgroup of people. The travellers is a very important crystallisation of a number of issues that have been a little woolly, and it's very good that that group is now represented and involved. So in terms of, NHS England to please answer the questions. But one thing that's come out of some of the conversation, not as an explicit question, but also off Twitter, that I would have already said to NHS England I will be raising on Monday, is that there needs to be an absolutely firm, crystal clear statement on the NHS England Care Data page that the pause is still in effect. The 6 months has run out, the pathfinders haven't been selected, and until the pathfinders are announced, nothing's going to happen. Because everyone's going, well, it ran out, is it now going ahead, is it not going ahead at all? What's the schedule? And the schedule is fictional. And so just sort of something that says, you weren't panicking a month ago, we're running late, there's still, until something is announced, nothing will happen. And I think that is a matter of public confidence from people who are very concerned. Irrespective of your views, is probably a very clear statement of that nothing's happening, even if nothing is actually happening that actually affects people yet. And sort of say, nothing will happen until we announce the pathfinders, and then these things will happen. Just so there's very, very clear process. And that's come out of today, it's come out of Twitter. It came out of the last advisory meeting as well, but that was 2 months before the end of the pause. We're now at, 6 days after the end of the nominal pause, and people are starting to get concerned.
Yeah, there's a huge thing about communication in this, which I agree with.
I guess I've heard, again, confirmation that there is a huge communication challenge that keeps coming back over and over. But I guess the only way that I know to frame this issue and understand it is that we're on a journey towards 21st century healthcare, and this is part of it. And the system has to learn and get better to be able to communicate with people and actually use the data that holds keys to better care and cures. And there are a lot of questions. The answers are rolling out slowly, but they're coming, and progress is en route. I guess that's what I'm hearing and confirming and understanding. And communication, people want more of it in the community, in the media, in their homes, in every way.
Great, thanks.
Thanks.
The one thing I do want to mention is there's somebody in the room who's written a really good blog that I've read, and it does highlight a lot of these questions. I'll embarrass her, she's sat there. It's Jen. Give us a wave. And we tweeted it around this morning, and I think we'll send a link with the post-event report as well, because it does quite neatly capture the issues that remain unanswered, the things that people are still talking about that haven't really been given a definite, and the things that are still up for debate and discussion that are of concern to people. So I would recommend you read it, and you can agree or disagree or provide a different view. Kieran.
Thanks. I'm feeling very modern. We're being tweeted, webcast, blogged all at the same time. What do I think?
This is 21st century participation.
Thank you, Olivia. We had the session at Peterborough, and it's back to us at the advisory group. There are things we think ourselves. We all have our opinion as a group. But the purpose of the Peterborough session, I think what it achieved for us was it made sure that we had the list of issues, and Sam said we probably could have sat down and thought of them, but it validated for us, I think, which ones we need to be asking more about, pushing more of it. And I think this has moved us on. I think there's a level of specificity we've had this morning, which reinforces some of our own opinions and prejudices, and probably says we need to push a bit harder on, let's take the traveller example as a sort of the encapsulation, as Sam was saying as well. I think we have to move to the stage where the programme is throwing out some of the answers, and those specific answers, not just we've got a more refined list of questions are being answered. So there was a session last week on the secure data facility. It was really good. It was very plausible. It got into this, there's the physical protection, there's the how do you select the people, how do you trust the people who will have access to the data. We need to get that out, and then people like ourselves can start saying, well, actually, yeah, I buy that, but you still haven't addressed this bit of it for me. So I think the programme more broadly, I think certainly on Monday when we have the advisory group, we'll probably be saying, okay, it's been great, we've heard all the questions, you've heard all the questions. Now, can you please just give us some answers we can test? The comms one, what are we actually going to say to the public in those pathfinders? You know, I know we haven't selected them yet, but surely we've been seeing some thinking around what that comms might look like. Can you show us that so we can say we like it, we don't like it, so on? So I think we have to, you know, be more specific. And one of the thoughts is when we have the third of these, which is likely to be somewhere in the northwest, maybe we do it in a slightly different way, and we move, because the intention has always been that the process builds on itself. So the next time, I think maybe we get some people from the programme along, you know, not just a couple, and say, okay, present some of the answers to us, and let's stress that those and do it in a slightly different way and more specific way, and, you know, pick out those questions and get the answers to it. Because I think we, you know, my view on the pause is it's this slow and steady stuff. You know, we're going to take, my suggestion is we take as long as we need to, and whether it's 6 months or 9 months or 12 months, I'm less exercised about, or more exercised about it happens properly. So it's not terribly specific as a summing up, but I think the programme just needs to switch phase. You know, yes, it's paused, yes, it's listened, yes, there's some really good work going on, but it needs to not be in its own locked room. It needs to be out there so that some of the rest of us, you know, can say we like it, we don't like it, it's moving in the right direction, or there's still gaps.
Okay, so my version of all of that is all the questions, we know what the questions are. We're not getting any new questions now. We're getting depth in some of the questions that are clarifying, so digging into the traveller and people with no fixed address issues, digging into the transgender issues, getting very specific. But actually, we know all the questions. Now we need to get some very clear answers that can then be communicated through a very diverse set of channels, be that local newspapers, be that community groups and organisations, be that the Archers. Let's get a storyline on the Archers about Care.Data.
I like the lots of front doors thing. I think that concept, I think we should keep.
So I think what we're saying then from this room today is that for November, if that's the next one of these advisory group conversations, actually we want to see some of those answers. We want to see some of those products that are going to help to communicate some of those things, and we want to see them in the context that you want to be able to pull them to pieces and test them and say yes, no, maybe, try harder. Is that a fair? There's no pressure on NHS England colleagues watching this on the webcast or on Twitter, obviously. Okay. Nobody's disagreeing. Okay. Sam is disagreeing. No, he's nodding. Sam's agreeing with me. Sam's agreeing with me. Oh, I feel honoured. Okay. Any final comments anybody wants to make before we close for today? Okay. Thank you ever so much for giving up your Saturday morning. I really cannot express how grateful we are for the generosity of your time, your insights, your expertise and your experience. Because without all of that, somebody said this to me earlier actually, you're the conscience of this whole programme. And having that collective conscience is just incredibly helpful. I hope the people watching on the webcast have found it useful and interesting, and I hope that we have tried to bring the Twitter conversation into the room, and thanks to all of you in the room who've also been tweeting and doing that connecting in and out. It's really helpful. Regional Voices will be producing a post-event report that builds on the Peterborough report that you should have seen with the joining instructions for today. And we'll endeavour to get that out as soon as we can, along with information about the what next and hopefully some answers to some of these as we start to pull those through. Rachel, is there anything you want to add?
Just that in an opt-out styly, what we said at the Peterborough event was that we'd like to build a bank of interested people who we can continue to go back to with the next round of events as well. So unless you tell us that you don't want to be part of that, and please tell us today, we'll add you to that list. You'll get the report anyway, but we'll also keep you updated on future reports so it can be a bit more interactive if you can't make future events.
There is lunch outside. Thanks for watching on the webcast. Kieran?
I do a thank you to the facilitators and to those who got up at 4:45 as well. But mostly, again, just to repeat, thank you for giving us your time. Thank you.